Let's talk about antibiotics. The World AntiMicrobial
Na hiyo antibiotic umetoa wapi?
Awareness Week Chingoja is marked every third week of November globally, providing an opportunity to reflect on the journey in antibiotic usage, gains and losses occasioned by rising antimicrobial resistance. And this is why we are going to have this conversation this morning as well, because we are trying to create that awareness about that. And joining us in the studio is somebody who is very well versed on these particular matters. He's a medical advisor in anti-infectives and urology at GlaxoSmithKline, GSK, Dr. Hiram Mwangi. Dr. Mwangi, welcome.
Morning, Eric. Morning, Muga. Thanks for having me.
It's good to have you on the show.
Yes.
We call this the hot seat, so welcome to the hot seat.
Thank
Let's
you.
see whether you can resist it, as you're talking about resistance this morning.
I will do it justice.
Okay.
Yeah.
Let's start with just awareness and definitions.
Yes.
What are antimicrobials and what are microbials? What are microbials?
Okay. So, in general terms, antimicrobials, or should we start with the microbials?
Yes.
Are the infective organisms that we have in our environment. That includes bacteria, viruses, fungi, etc. And antibiotics are the agents that have been created, chemical agents that are there to help us fight off these infections when they affect us. And by us, I mean both humans and animals. And that's an important point because we'll see the application of these molecules across the board.
Okay.
Yes.
So that is so. What it then is antimicrobial?
Resistance. So antimicrobial resistance is a situation where those target microorganisms develop mechanisms by which they stop responding, or the chemical agents that we expose them to in order to clear those infections become ineffective against those microorganisms. So you find a situation where a simple infection that would previously be treated with a certain antibiotic or a certain antimicrobial agent becomes difficult to treat. So it takes more antibiotics to treat, longer durations, or sometimes even a combination of things for you to succeed in treating it.
There are those who've said that a discussion such as this one
Yes.
was only made possible when penicillin was discovered.
Yes, in actual fact, that's true. That was a very important time in medical history, and we call it modern medical history, where at some point penicillin was discovered in the late 20s. And around that time, infections were a very dicey situation to get into. And in fact, if you look at the statistics of World War, it would be easier to die of an infected injury than perhaps being on the battlefield.
Yes.
So it was quite a significant step in advancing, survivability from different infections, leave alone in war situations, even in the social setting where, infections would normally result in death. So upon that discovery, one of the key things that was raised by the people who made those discoveries, Alexander Fleming to be specific, is that he called out a risk that existed, that yes, we've discovered penicillin, but the risk here is that in time, this bacteria will learn how to defend themselves against these antibiotics. And if we don't use it appropriately, if we don't use it rationally, that's what's going to happen. And that's the exact situation we're in at the moment to some significant extent.
Okay. So is it because of not using it appropriately, not using it properly? Is it because of the wrong application of the available antibiotics that then the microbials are becoming resistant?
Yes, so there are a number of drivers, and I think you've more or less called them out. There's things to do with inappropriate antibiotic use, overuse of antibiotics, misuse of antibiotics, such as them being available over the counter for anybody to just request for them when they feel like they have an infection that needs it, while in most situations that's not the case. Also, using broad spectrum antibiotics for situations where they really are not necessary or needful in application. So a combination of different factors driven by different players in the antibiotic situation. There's what clinicians do that can be classified as inappropriate. There's what industry does, and by industry here I mean the manufacturers of antibiotics, and that is not looking at the quality of antibiotics in the right way. And then there's also the use of antibiotics in agriculture, which can sometimes be quite unregulated and risky. And you see, we share an environment, and once this bacteria exposed to these antibiotics in the environment, they learn how to defend themselves and eventually get to us and cause us trouble.
When you talk about antibiotics,
Yes.
there is a term that I have found puzzling. I don't fully understand it.
Yes.
And it's the word synthetic with reference to drugs.
Okay.
Okay?
Yes.
Now, you are in that space where people produce drugs.
Yes.
So, what is the benefit of drugs that are labeled synthetic, and what is the option that one has beyond the synthetic?
Okay. Synthetic, in this case, would be something that perhaps is not naturally produced by a living organism. For example, most antibiotics are or even just drug technology in general, you'll find that there's genetic technologies that are used. And we actually use bacteria, for example, to produce insulin. You generate
use the bacteria to produce
insulin.
Yeah?
Yes. So such situations would be what you'd call more or less the opposite of what synthetic is. And then a synthetic situation is where now you combine different chemical compounds to come up with a unit that you would call a drug, for example. So it just doesn't apply to antibiotics. It goes beyond antibiotics.
So essentially, anything that is a chemical concoction and isn't derived from a living organism, like say a plant, would fall into that category.
It may fall into that category.
The reason why I asked this, I was listening to BBC the other day, and one of the things that they said has come out of America when they're looking at COVID and the effects of it is a component of harm that was brought in because of COVID, and it was overdosing. That people ended up being, because of the confinement, people were self-medicating.
Yep.
In the process of self-medicating, they ended up taking drugs, bigger dosages than they wouldn't have if they had actually sought professional help or professional guidance. So now, when one talks about medication, and one of the drugs that was mentioned in passing when I was listening to this particular interview was a drug called fentanyl, okay? And what they were saying was some of these drugs that fall in the broad category of opioids is that they are actually 5 times, up to even 5, even more powerful than the actual drugs that are offered as medication. So if someone takes it and doesn't know exactly how to use it, you'll likely overdose not knowing that you're overdosing. Now, let me explain why I brought in the discussion of synthetics. Now, if we are talking about a provision of health care through medication that makes your life better, is there adequate education to ensure that people understand the dangers that are presented by these very, very same drugs that are supposed to actually make their lives better?
Well, that's a definite issue for sure. In terms of public knowledge,
Yes.
it's not at the level where it ought to be, and this presents different challenges in different situations. So I'll look at a situation of, say, acute care,
Yes.
and then I'll go on to discuss something about chronic care. So when you don't understand, for example, what an antibiotic is meant to do, meant to treat, how it's supposed to be taken, the discipline behind the consumption of these drugs, then you're at very high risk of doing things wrong, especially when you don't get good guidance from your healthcare providers. And with, like in our setting, you find that it's very easy and possible for someone to walk up to a pharmacy, ask for medication, and just take it home with him. And yes, there's an element of guidance, but you're also offering it to someone who you assume understands what is supposed to happen. So that is in the acute care setting and maybe with application to antibiotics. Now, if you go on to chronic care, for example, if you go to hypertension, just as an example for the discussion, you find that people do not understand the disease process well enough to understand what the drug comes in to do, how long they're meant to take it for, and some of the side effects they can expect, some of the safety issues they ought to expect, and also what they need to look out for and maybe inform their healthcare provider. So it just brings up the situation that we need to educate everybody about what these different chemical compounds do to them and what they need to watch out for. You ought to challenge your clinician also to, like when you go to hospital, you really can't just sit there, listen to instructions, walk to the pharmacy, get your drugs and go. You have to challenge them, ask them good questions, try and understand your situation.
You know what a doctor will do?
Yes.
A doctor will just throw in that heavy word.
Well,
This one contains 5 mgs, so it's good for you. You're lost.
Well,
How can you counter that?
But Eric, we have a much better understanding of different things we consume in our environment.
Yeah. No, I mean,
people know the ingredients in their bread,
when you come across
in their
somebody,
alcohol, but they don't want to put effort behind understanding the medication.
If you come across somebody who is willing to share information, in fact, you don't even need to ask. So they'll take you through, okay, so tell me what you're feeling like. Have you experience this and the other? So I'm suspecting this. Let's go into this regimen. I'm going to give you this. This contains this and the other. They'll take you through it. And you can ask questions.
Yes.
And then you go to a different professional who is basically just thinking, I hear there's a queue of 40 people out there.
40 people, yes.
All right? So tell me what you're feeling like. Okay. I suspect this and the other. This. Go and take this. So what is this for? This one is going to help you. Go, man. Step out. There are many more people.
Yes.
You see, now those are the challenges.
Yes.
To show how
Agreed.
serious this is, there's a story today on page 8 of the Standard, written by Matilda Mbenywe. Kenyans abuse antibiotics, painkillers in wet evenings. And it talks about a cross-sectional survey titled Antimicrobial Resistance Knowledge Among Kenyans that revealed that antibiotics are the most sold product in 58% of agrovets and 43% of pharmacies, where the sale of antibiotics is only rivaled by painkillers, cough medicine, and antiparasitic drugs. It goes on to say antibiotic sales contribute to 38.8% of total revenues in pharmacies and 30% in agrovets. More than 2/3 of human drugstores sold antibiotics without a prescription compared to veterinary drugstores. So they are available.
Yes.
They become like the first thing that you go into hospital. Okay, here.
Yes.
Take this for 7 days.
Yes. So well.
And this is just at the pharmacy.
Yes.
And because someone is telling you this one will sort you out, you don't start asking, so what does it contain, this one? I just finished another dose of.
Yes, I agreed. The first to look at it rationally is to understand that maybe we're in a situation where infectious diseases are amongst the highest in frequency in any healthcare institution in the country. So naturally, you'd expect that antibiotics would be one of the highest consumed pharmaceutical products that there exists. Now, within that situation also, there's a problem where some degree of inappropriate application, overuse, excessive availability, and lack of control, that ability to get that antibiotic over the counter without a prescription is a concern. The article you mentioned also includes agrovets.
Yep.
And agrovets now speak about animal health. 70% of antibiotics produced in the world are consumed in agriculture, and that is in animal health. So be it fish farming, dairy farming, poultry farming. If you want to accelerate your timing from chick to plate, from 100 days to, around 42 days, antibiotics can accelerate that process. And you can imagine that exposure of antibiotics to the environment. And by environment, I mean to these microbes that we are targeting. Those things then find themselves into us in one way or another through food and water contamination, respiratory infections. And they've already had a taste of what we want to treat them with. And that makes it difficult now. Now you either have to use more antibiotics or higher doses of antibiotics, or you have to treat patients for longer. Some patients are not lucky enough to survive the situation, and it brings a problem. So there's two ways to look at the article. There's rational use within that space, given the disease frequency that we experience. But then again, there's also some situations that are actually inappropriate and wrong. Yeah.
So where are the weak points then? In terms of, because there are some weak points in the control system.
Yes.
Where are these weak points? Is it in law? Is it in just application? Or is it in practice?
Well, it's in numerous points, and I think I'd look at it in terms of proportionality. I'd not, give it a blanket statement and say that everything is wrong. Okay, because one of the things that that have been defined by WHO as important in curbing the infections that we face is to be able to access antibiotics in the right way. But now that right way is through a clinician who is able to have a look at you, come up with the correct diagnosis, and make sure that he's actually treating a bacterial infection before he recommends. Yes. So the lack of perhaps that capacity and access to the healthcare provider in some situations and for some people can be an issue in certain situations that now pushes them towards over-the-counter use of antibiotics. And the pharmacist now sits at a very important point, in terms of being the last, stopgap measure.
Daktari.
He is a daktari,
Actually,
and he's actually a very trusted daktari.
Not only trusted, he
And
is actually the expert
Yes.
in these drugs, not the medical doctor.
The medical doctor sits further up,
Yes.
but the pharmacist to the society is the guy on the ground. So he plays a very significant part, very important part in this.
Hiram, let me ask this question.
Yes.
When pharmacists, doctors, dentists are trained,
Yes.
how many units in this country are dedicated to communication? Communicating with the patients. Because let me explain to you why it is I'm asking this
That's a
question.
good question.
At the end of all that discourse, take a deep breath, stretch your arms, hold your knee, all that, okay? There will be a prescription.
Yes.
Okay? Now, the prescription with some doctors is preceded by an explanation.
Yes.
And you're walked through.
Yes.
When you go to the pharmacist, pharmacists rarely walk you through. They simply dispense. You say this is what you want, they give you. And yet, they are actually in a really key position to explain to you and tell you, by the way, this is what you take, but let me just remind you again
Yes.
that this is what this does. Hence, my question,
Yes.
dentists as well, how much time, how many units are dedicated to communicating this important role that these people have and the outcome of it, which is them dealing with another human being and helping their lives improve?
Yes. So here's how I'll put it. When you say units, I'm looking at hours spent in a communication course, perhaps in training. So in essence, within the curriculums that we go through, it's not structured in that manner. So we look at medicine as two things. There's the science and there's the art. The science is the understanding of everything, the disease process, the theories, the practicalities, how anatomy and everything. But the art is now in the application of that science. And within the art comes in communication. One of the most time-consuming aspect of a doctor-patient interaction is what we call history taking and the explanation of what it is that the doctor has found. And I think medics actually do it justice. They will listen to you. They will ask you simple questions. What is the problem? How are you feeling? And many others that tend to bring out what brought you to hospital and everything. That usually indicates to us the lines of questioning and examination that we ought to take you through. Then at the point where we are explaining what we found and what we think is happening, we actually walk you through our findings and our thought processes, whether it will result in a prescription, further investigations, a review later on, etc. Now, I remember during one of our steps towards graduation, one of the professors did tell us that from everything that you've learned in all your years in this medical school, if you cannot explain the problems that you've discovered in a patient to your grandmother, then your learning has been pointless. So you can imagine. So communication forms a fundamental part of medical learning and practice. It is not broken down into units as you put it, but it is a basic tenet in what we do on a day-to-day.
Our guest is Dr. Hiram Mwangi, medical advisor in anti-infectives and urology at GSK, and his hosts are Eric Latif and CT Muga.
The question I wanted to ask was actually twofold. One, remember the question of communication. You see, when someone is trained in any field and they are then unleashed onto to the unsuspecting public, they're usually very enthusiastic and they want to follow the rules as they are written. Over time,
Textbook.
Kabisa. Over time, they acquire habits that are drawn from the practice. Now, it's at the point when they acquire these habits, when they now feel and think that they're actually experts and don't need anyone to tell them anything, that they probably need to be retrained so that they remember where it is they started. Now, why does this become an issue? When you have a situation such as the one we've had with COVID, where it is something that is strange to everybody, people who are trained in medical care, the pharmaceutical, everybody doesn't understand this disease fully, and yet they're trying to manage it. So now, the other weapons we've been using on diseases, they are the antibiotics we've been using, they are all these things that we've been using, and then throw in every other thing that masquerades as a healthcare product comes into play because we do not know. Dr. Hiram.
Yes.
With all the training and all the understanding that people have,
Yes.
look at the COVID situation, look at the treatment process, look at the application of antibiotics into it. The dangers we've heard that have been posed, the problems that are brought about by ignorance. Tell us about it.
Well, COVID-19, I think, is one of those moments that, help us reflect, although it doesn't give you the luxury of time to think through things and reflect. One of the reasons why it's such a dangerous situation is because we don't have a specific solution to it. And I'm going to very directly compare it to the situation we face with antibiotic resistance. Imagine if the bacterial infections we're able to treat today, we are not able to treat tonsillitis, pneumonia, diarrheal disease, just because these bugs don't respond. That is what COVID has brought to the fore. Okay? Now, if you look at the clinical situation around COVID, I think the information and the data around COVID-19 and the different approaches to care for different patient profiles. By patient profiles, I mean how people present. Some with mild disease, some with moderate disease, some with what we call comorbidities. It's getting clarified over time. We understand who gets to experience the disease worse. We understand who needs different kinds of levels of care, from outpatient management or home-based care, in-hospital management, and even more intense forms of support within hospital. The key problem for me at the moment, and what concerns me the most within COVID-19 management practice, both with certain clinicians and also with patient expectations, is the use of antibiotics in COVID-19. You find that there's data out there that looked at more than 3,500 patients who had COVID-19, and what they were trying to establish is what kind of treatments were they on in terms of antibiotics. More than 72% of those patients had been put on an antibiotic. Of those 72%, or within that population, only about 6.9 or 7% of them required the antibiotic. So a lot of that antibiotic application was inappropriate.
So the antibiotic was being used in the treatment of COVID.
As an add-on treatment to the process. It's a concept we're calling the just-in-case use of antibiotics.
Yeah.
By just in case, I mean,
You don't
I
know
know you
what's
have
coming.
COVID. It is a viral infection.
But just in case.
Possibly
know
there
there's
could
no-
be a bacterial
we
infection
know there's
somewhere.
no
We'll
cure
throw
for
in
it.
something.
Because with viruses, there is no cure.
Yes.
You know, Swahili puts it better. Yaenda ikawa.
Yeah, just in case. So there could be a bacterial infection in the background that I'll just throw in this antibiotic for. But I've not verified whether that exists. I've not done the right assessments and investigations. Yes, we know that sometimes viral infections precede bacterial infections at a rate of, 95 to 5 to 10% of situations. You will start with a virus, then
And then it goes into
become
bacteria.
secondarily infected. However, to actually be an appropriate antibiotic user, you ought to actually do it right. Don't take shortcuts. Don't use the just-in-case situation. So that accelerates antimicrobial resistance. And like I said at the beginning, imagine if we get to a point where we can't treat these things anymore.
You know what I
You
find?
run away from this world.
Something like COVID,
Yeah.
which is still confusing
Yes.
the healthcare world. One hears of stories that we went beyond antibiotics and got into antiretrovirals. Now, what antiretrovirals do is known. How they go about their business is known because HIV is also a virus.
Yes.
Now, when you find yourself in a situation such as the one that COVID has provided, the just-in-case rule,
Yes.
does it then not acquire greater license?
Well, it has.
Okay.
Which is
I was about to argue that. I mean, you don't know what you're facing. And like you said,
Yes.
if there's a 10% chance
Yes.
that this viral infection could be preceding a bacterial infection, which will make your situation worse, your body weaker and all, and we don't actually know what we're dealing with,
yes.
let me just give it to you. Because if you had come in and you have a bacterial infection, I would have given you antibiotics anyway.
Well, if
And at
I
this
had
point,
proven
well,
it.
at this point is, we are talking about it was a medical emergency. It's a completely new thing, and it's taking the world away from us.
Yes.
So probably that's the license that SCT is asking about. I mean, at that point, when you're faced with that, go ahead and throw the kitchen sink at this thing.
But then again, it doesn't really help. You're targeting a virus with an antibiotic. You're trying to, sometimes we used to say, when you're targeting a very simple infection with
It's
a very big
A
antibiotic,
mosquito bite with a hammer.
it's like shooting a mosquito on a wall. But this is not even that situation. This is totally inappropriate. It's like
Blowing up the house to kill a
giving a
mosquito.
fish a bicycle, for example.
But
Giving a fish a bicycle.
It's really not. It's totally off.
No, but Dr. Hiram, think about it for a single second.
Yes.
I'm saying this purely as a layman.
Yes.
Here you have something that has manifestations that are dangerous.
Yes.
And some of them bring about outcomes that you actually understand, like, say, pneumonia. Now, you have and you understand treatment for this,
Yes.
But with that also, they come with other, meaning it is a concoction of things that you are faced with.
Yes.
Now, surely, as a medical practitioner, are you not going to use everything within your arsenal to try and see which one of these works?
Yeah. Well, there's a point, but then again, even if you look at it from like a war situation, war is very confusing, and you just want to throw everything at your enemy. But you need to know what to apply in what situation.
True. That's why
You have to be very, very sharp in
That's
what
why
you're
you
doing.
have strategists, people who are experts in war.
Exactly.
Now, in this particular war,
Yes.
it's the medical
Yes.
doctors and the pharmacists
Yes.
who are the experts.
Yes.
Because we don't go around prescribing the antibiotics for ourselves. Neither do we say, given that I can't breathe properly, what I recommend you give me. No, no.
Yes.
It is you,
We who give them.
the expert, who tell us, this one of yours, given that it's on the left lung and it seems to be tickling the upper side of the throat, the antibiotic that we think is suitable for this one is this. It's you who prescribe it.
Yes, in the right circumstances, yes, and
Yes.
and with the right information in support of the decision I will take, I agree. But people sometimes take that information, misinterpret it, go get a positive COVID test, say in a hospital.
Yeah.
They are not severe enough, so they're released back home for home-based care, and the right measures and advice is given to them. But what they end up doing is, I think I might think of adding something else to myself.
Or so and so says.
Or
Yeah,
so and
they
so
were using
says.
this.
Of course, Dr. Google doesn't help in this situation. He
Dr. Google
provides
doesn't
information,
help at all.
and people use that information.
Of course, yes.
Much as you may judge it from a different perspective, the
somebody-
interpretation out there is very, very confusing. So they end up going after so many different things. You find someone with 39 different things they're taking for what they're going through. But those things are not effective, and they're not going to help them. They're just worsening a problem. It's inappropriate use of medical therapy. And I think for healthcare providers, with evidence building up on a day-to-day basis, we're understanding the situation more and more, and the outcomes are actually getting better and better as we go.
But there's one aspect of healthcare that unfortunately has had to come under fire.
Yes.
The commercial aspect of it. Because there are those who argue that those in that space have taken advantage of it because people know that their lives are in danger and they don't really know what to do. They've used the knowledge they have to know that this thing won't kill this person, but it will definitely cost more. Because COVID and the treatment of it is one of the most expensive things we've actually experienced in this century.
It can be, yes.
Yes. Can be, Dr.
It can be in when things get rough, yes.
You see, where the problem arises is we're coming from a background where already healthcare provision has been under fire as being extremely expensive, especially private healthcare. So now you throw in COVID and the costs that have been attached to it or related to it, especially when somebody has passed away and there's a lingering cost that still has to be settled. And if you look at it, it is more to do with what was provided for you
Yes.
from the pharmaceutical space and which was prescribed by experts. Now, the communication I was talking about earlier,
Yes.
now, do you see where it comes in and where it's important?
Yes, it is.
Because if all these things are explained to the patients, their relatives, and they have an understanding and options provided, yes, the discussion would still be there in some cases, but it will be infinitely lessened.
I want to also add on to that the issue of the controls that we have in place. So, for instance, if a majority of the antibiotics that are being sold in the market are being sold over the counter at pharmacies, it means that somebody is going and saying, I'm feeling this and the other, and the pharmacy, the one person wearing a kabuti on the other side of the shelf, of the counter, just tells you, so this is what you need to take, and this. Now, the question is, does everybody who work in a pharmacy have the qualifications of being a pharmacist to that degree of prescribing and dispensing? Is that what we have? And then what controls are there in law on how you, that entire process of walking until the point where you receive your medicine, you walk out? What are the controls in place?
Eric, can I just add something before Dr.
Yes.
Hiram tries to?
Yes.
There is the pharmacist, there's the pharmtech.
There
Yes,
lies your
all
answer.
those are
Yes,
the ones I want to
I
understand.
want you to explain
Because
to us.
yes,
as far as all of us are concerned,
Pharmacist.
you walk into a pharmacy, you are finding a pharmacist, somebody wearing a white lab coat.
Yes.
You tell them, nasikia hapa hivi, haya nasikia ilianza lini, unasikia pande hii. Okay, yeah, I think you can take this one. Hiyo ni pesa mingi sana. Aya, usichukue basi hii. Ni kama tuka hii, lakini hii sasa. So, who are all these people?
So in any pharmacy setup, a standard pharmacy setup, and for it to be allowed or licensed to operate, there ought to be a pharmacist and the pharmaceutical technologists manning it. more or less. And I'm looking at it outside the hospital setting. In hospital settings, that prescribed situation definitely exists. Now, when you go to the community pharmacists, and if you look at the situations around resourcing, capability, and the degree of qualifications and the numbers of those people available, you'll find that a good majority of them will have a similar setup. But towards the grassroots, you'll find that community pharmacists are manned by the pharmaceutical technologists. Okay. Now, within that pharmacy, the person who is responsible for and can actually prescribe an antibiotic, for example, or a drug that requires a prescription, we call them prescription-only medications, is the pharmacist. The pharmaceutical technologist is supposed to provide advice around the consumption, utilization, storage, and the dispensing
It's the one who right there. Two
he's
times
the,
three.
He's the one who, he's the one who
take
interprets what the
with a
prescription.
lot of water before meals, blah blah blah.
Okay. He's the one who gives those endpoint instructions. Now, at times you will find that some people may go beyond their mandate, and on the balance of things, do we have enough resources to have that ideal situation everywhere? Yeah, exactly. So sometimes that's not possible. So what do we do in that case? It's a capacity building exercise.
Okay.
Make sure that the farm tech himself is also competent enough to understand certain situations and to recommend certain lines of action. And when it's beyond a simple piece of advice and requires more evaluation and maybe additional analysis by a more qualified medic, then he should be able to refer the patient up in the right ways.
On paper.
That's how I do it.
On paper.
Yes.
Now, who licenses pharmacies?
And that mandate lies within the Pharmacy and Poisons Board.
Yes. And they're the ones who will come and see that this pharmacy is well structured. It has the required personnel.
Yes.
This is a pharmacist, is the one who's licensed, is the one in charge.
Yes.
And then the farm techs are here.
Yes.
All right?
Yes.
Now, when they go, is there, like you're talking about capacity building, understanding where we are, and understanding the number of pharmacies, qualified pharmacists that we have available for the country.
Yes.
Is there any program that has been rolled out by the board on that capacity building, saying, I want to come and keep doing regular tests to see whether you actually are competent enough? Yes, you first of all are qualified as a farm tech. A farm tech has what? A certificate or diploma?
It's a diploma.
It's a diploma, and this is from KMTC.
Yes.
Right?
Yes.
So you have that basic, so you've gone through the basic training.
Yes.
Now the next level of understanding, like you're saying, Dr. Hiram,
Yes.
does the board do that? Does it have any such kind of program?
Yes. In fact, I look at it from a healthcare professional standpoint. So whether it's medics, dentists, pharmacists, farm techs, nurses, we have a requirement, an annual requirement to participate in what we call continuous professional development activities, CPDs. And these are actually sessions, or meetings, or workshops, or training situations that we have to attend. For each session you attend, you get points.
Points.
And you have to satisfy a certain threshold for your license to be renewed.
Yep.
So capacity building does exist. There are a number of different stakeholders or partners within the market that support those situations. The schools themselves, institutions of practice, that is hospitals, pharmacy chains, industry players like drug manufacturers like ourselves.
Like GSK.
We also have global partners like WHO, FAO, etc. So there are so many opportunities for capability development in courses that are actually tailor-made to improve practice, to ensure that people are doing the right thing. One of the things I can highlight, as one of the responsibilities I have at GSK, and one of the mandates that was issued to industry players by WHO in the AMR benchmark project in 2016, is to ensure we raise awareness on antimicrobial resistance, as an example, and encourage and educate stakeholders on antimicrobial stewardship. Antimicrobial stewardship means, as an institution, as a group of practice, as a certain cadre of practitioners, the part we play in the antibiotic consumption process is actually as it should be, based on guidelines.
How do you do this?
How we do this is antimicrobial stewardship is a program that is run at institutional level.
Institution as in training institution?
No.
Or hospitals?
Hospitals, even at your pharmacy, it's a program that you run across.
Can you find it online?
No, stewardship just means how we control ourselves.
Yes, but surely there's a curriculum.
Oh yes, there is a curriculum. There's lots of resources on AMS.
So there are people who actually taught the curriculum and then they pass on the information.
They pass on the information.
Why don't you have it online then?
It is available, and people have access to this material. People have initiated stewardship programs in the institutions. We, as industry partners, actually present data to these antimicrobial stewardship committees for them to make informed decisions on how antibiotics can be used in the institutions. Yeah. So, as drug manufacturers, it's our responsibility to make sure that actually happens on the ground. And I'd be shooting myself in the foot twice if I'm just sitting happy looking at antibiotics getting consumed, knowing very well that resistance is developing around them, and in a short while, it will no longer be working.
Yes, and then
So
you'll come up with a new drug.
Which will be more expensive.
Now,
Yes, and you'll be told works better than the previous one.
the story of new drug development, for the last 35 years, we've not had a new antibiotic class come out.
Why?
Because it's difficult. And the options are limited.
That is what you say.
That is the problem.
That is what you say.
That is the situation, Muga.
So as we conclude,
Yes.
Dr. Hiram, what would you say is required from where you sit, from what you've seen as a practitioner?
Yeah.
What is required to make the public more aware and more cautious about how they're using antibiotics?
Okay, so I think in line with the theme for this year around World Antimicrobial Awareness Week, the idea is to spread awareness and to stop the spread of this issue of antimicrobial resistance. So this awareness should be spread through public-driven campaigns, on one-on-one situations, when medics interact with patients, when pharmacists interact with patients, they need to explain the circumstance that we are in, and in a way that the patient is able to understand. Institutions have a part to play, and that is to roll out, implement, and strengthen the antimicrobial stewardship programs.
Okay.
Industry players have a part to play. Responsible manufacturing, encouraging and conducting education on appropriate antibiotic use, and also working in research to develop new products that will remain effective, new vaccines that are very powerful agents in actually saving us in infection control and prevention is also a primary thing that we ought to do.
Thank you very much.
Yes.
Dr. Hiram Mwangi is from GSK, is a medical advisor in anti-infectives and urology. Come again and let's continue this conversation.
I shall.
Asante sana.